Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. Today we'll be dealing with one of the very interesting topic which you see in your everyday practice good number of times, as well as this can be asked as a short note in your theory as well as in your oral exam, that is hyperkalemia. Meaning is very simple. Hyper means increased, Kale means potassium, emia means in blood. So potassium level more than 5.5 milliequivalent in blood is labeled as hyperkalemia. We'll be discussing under all this heading, that is definition, etiology, pathophysiology, clinical features, investigations, differential diagnosis, treatment and complications. By definition, it is very simple that any time if there is an elevated level of potassium in blood more than 5.5, it is labeled as hyperkalemia, and then it is divided into mild, moderate and severe. If level is between 5.5 to 6, it is called mild. From 6.1 to 7 is called moderate, and more than 7 is considered as severe, and it can be lethal. So potassium level more than 5.5 in blood is hyperkalemia. So it is being classified as few terms: mild, moderate and severe. We have already mentioned 5.5 to 6 mild, 6 to 7 moderate, more than 7 severe. There is one word called as a pseudo hyperkalemia, where the level of potassium is elevated in blood during collection. We'll be talking about that. And there is true hyperkalemia, which we'll be also discussing. And then we divide according to the etiology. Now, before we go to the etiology, clinical features, etc., if we understand the normal potassium metabolism, action, etc., everything will become simplified. So I am going through that. Potassium is maximum intracellular cations, while outside the cell, that is in an extracellular compartment, it is between 3.5 to 5.5. And this particular is maintained by sodium potassium pump. Extracellular sodium is high, intracellular potassium is high. This particular tries to maintain the electrical potential across the membrane, which is required for repolarization as well as depolarization, and that is going to help normal function of the nerve, muscles as well as cardiac tissue. Now potassium, when it moves from extracellular fluid into intracellular fluid, you require sodium pump to be active, and whenever the imbalance of potassium occurs outside the cell, the most important structure which is being affected is myocardium. Second common structure which is affected is skeletal muscle, and third is smooth muscles. And this becomes very, very important to know what exactly is happening in potassium. This is one simple diagram which tells you that sodium, whatever we take orally, is absorbed from GI tract, which enter into blood, and from blood now we'll have all the distribution. So we'll have filtration in a glomerulus, of which almost we say that 90% is reabsorbed. So anything which happens to the kidney, severe renal impairment, will alter the potassium level. as well as anything which happens to the GI tract, where GI tract loss is increased, there will be diminished potassium level in blood because of reabsorption, because of absorption from GI tract, sorry. And this reabsorption in a kidney is affected by angiotensin 2, aldosterone and cortisol, which will be acting at distal convoluted tubule and collecting tubules, as well as the potassium will exchange with the cell by what we call as a intracellular transports and intracellular shift, which will be affected by insulin, catecholamines, beta blockers, beta blocker antagonist, alpha receptor antagonist, etc. All those will have effect as far as the intracellular shift is concerned. We'll be discussing further. So dietary intake is around say 100 milliequivalent, of which 10% will be excreted out in stool, 90% will be excreted out in urine. Indirectly, almost whatever is absorbed from GI tract is thrown out. So very nice balance is being maintained. Now whatever is absorbed from GI tract, 2% of that will go into extracellular fluid compartment, and then it will be exchanging with intracellular compartment, which is 98%. Now this intracellular shift will be affected by insulin, beta 2 adrenergic stimulators, alkalosis, which will shift potassium inside, while acidosis, increased plasma hyperosmolality, alpha adrenergic stimulators, exercise, etc. will shift the potassium from the cell, inside the cell, that is intracellular compartment, into extracellular compartment, producing hyperkalemia, while insulin, beta adrenergic and alkalosis will result into hypokalemia. Aldosterone, potassium plasma level, sodium delivery, urine flow and renal injury, particularly AKI and also CKD, will have influence on reabsorption of potassium in distal convoluted tubule. So this will be the factor which will be affecting potassium homeostasis. That is the material which produces intracellular shift, the material which produces extracellular shift, and material which produces urinary potassium reabsorption in a distal and collecting tubules. So whatever we take orally enters through GI tract into bloodstream, and then it is almost, we say that 90%, say if 80 milliequivalent, 70 milliequivalent is thrown out in urine, 9 milliequivalent will be thrown out in stool, and remaining either through the skin in the form of a sweat. And the shift, we have already told you that potassium will be shipped out because of hyperosmolality, exercise, cell lysis, as well as we have shown you that it will be shifted out because of alpha adrenergic stimulators as well as acidosis, while intracellular shift will be because of insulin, beta agonist and alkalosis. So this will result into hypokalemia, and this will result into hyperkalemia, and that balance is very nicely maintained by sodium potassium pump, where 3 molecule of sodium will be exchanged with 2 molecule of potassium, and constantly the balance intracellular 98% and extracellular 2% is being maintained. This is what we call as a potassium homeostasis. So in an intracellular compartment, around 140 to 150 milliequivalent is being maintained, and in an extracellular between 3.5 to 5.5 is being maintained. Roughly we say 3.5 to 5. So in a distal convoluted tubule, you will have exchange of sodium and potassium, and this will be affected by aldosterone and by other factors also, which will be acting at the level of distal convoluted tubules. So kidney plays a very important role in maintaining potassium balance by action on a distal convoluted tubule. So potassium, overview of potassium balance here. Potassium is not consumed, potassium is not produced. Dietary potassium will enter into the blood by GI tract absorption and will be thrown out by urinary excretion, GI loss and transcutaneous loss by means of a sweat. And there will be constant exchange between intracellular and extracellular compartment. So there will be factor which will be increasing the potassium level, that is shift from intracellular into extracellular, like excessive intake, urinary excretion, decreased urinary excretion, decreased GI loss, decreased transcutaneous loss and transmembrane shift. While hypokalemia will be because of poor intake, increased urinary excretion, increased GI loss, increased loss in a sweat and transmembrane shift. If we understand this simple thing, then hyper as well as hypokalemia becomes very simplified. So transcellular shift plays a very important role, as well as dietary intake and loss play an important role in homeostasis of potassium in human body. So three mechanisms will be playing a role: intake, output and transcellular shift. There is something called as a pseudo hyperkalemia. We'll be talking about that. There will be drugs which will be having effect on kidney, like ACE inhibitor, ARB, diuretics. We have got two types of diuretic. One which will be preserving, which will reduce the reabsorption, excretion of potassium, and there will be one which will be increasing the excretion of sodium as well as potassium, we call as a loop diuretic, and one which will preserve is we call aldosterone antagonist as well as potassium sparing diuretic like triamterene and amiloride. This will be potassium sparing diuretic, as well as AKI and CKD will also have effect on absorption and loss of potassium via distal convoluted tubule. There is one condition which is a genetic condition like renal tubular acidosis. So there will be exchange of potassium with H ions, and that will also result into abnormality in homeostasis of potassium. So aldosterone plays a very important role. Glucocorticoid also play a little role in potassium balance. And we have already told you diuretics, two types of diuretics. Now why this is important? Because there is an electrochemical gradient across the membrane, particularly in the muscles which are contracting like cardiac muscle, smooth muscle and skeletal muscle. And there is a resting membrane potential. And this resting membrane potential is required for a contraction of smooth muscle, cardiac muscle and skeletal muscle. This is being maintained by a very nice balance between intracellular and extracellular potassium, which is maintained by sodium potassium pump. Anything which disturbs this particular balance will disturb the depolarization and repolarization of membrane of smooth muscle, cardiac muscle and skeletal muscle, leading to abnormal contraction of smooth muscle or absence of smooth muscle contraction leading to paralytic ileus. When it is affecting the skeletal muscle, it will result into weakness, flaccid paralysis, and it will start more with lower limb and then may also involve upper limb. And in cardiac muscle, it will result into cardiac arrhythmias and can end into cardiac arrest. So that's the reason why this is absolutely important. Both hyperkalemia as well as hypokalemia will have effect on all these three groups of muscle, that is smooth muscle, skeletal muscle and cardiac muscle, of which the cardiac muscle is lethal. So external balance and internal balance shift is absolutely necessary to maintain a very nice balance across the membrane. If that is being disturbed, it will affect transmembrane potential and results into abnormal function of skeletal muscle, smooth muscle and cardiac muscle. We have already mentioned that hyperkalemia. Now we are going to talk regarding hyperkalemia. So any condition which increases the potassium intake, this is very frequently iatrogenic, like IV potassium salts like pot chlor, or oral intake, excessive intake of potassium, or in the form of a diet like coconut water, banana and other fruit material which is rich in potassium. Or once in a while when you give a penicillin IV, which is a potassium salt of penicillin, can end up with hyperkalemia. The another important part is potassium shift from intracellular into extracellular compartment. This will be in case of diabetes, particularly type 1 diabetes mellitus. If a person is on a beta adrenergic antagonist, or acidosis, particularly in case of a diabetic ketoacidosis. It is not commonly seen in a lactic acid acidosis or in a case of a person with other acidosis like respiratory acidosis. Usually shift of potassium does not take place. Also, if there is a destruction of the cell like cell lysis in traumatic injury, hemolysis, also if there is a massive thrombolysis or there is leukocytolysis, thrombocytolysis, or if there is a tumor lysis, there will be increased potassium released from the cell and that can produce hyperkalemia. And there is one very odd variety which is genetic called hyperkalemic periodic paralysis. Occasionally, kidney, due to decreased excretion from glomerulus because of decreased GFR, particularly in case of AKI, oliguric AKI, or in a case of a renal tubular acidosis, potassium excretion is reduced, can result into more potassium preservation, hyperkalemia. Also, if the person is on a drugs like potassium sparing diuretics or aldosterone antagonist, will result into potassium elevation, as well as drugs like ACE inhibitor and ARB will also result into potassium reabsorption is reduced from distal convoluted tubule, and that will also end up with high potassium. Also, in case of an adrenal insufficiency, you can have a potassium elevation due to cortisol deficiency. And in case of an acidosis, with H ion shift intracellular, potassium will be shifted outside, and that will also result into hyperkalemia. These are all the etiology as well as pathogenesis which will produce hyperkalemia. So we have got two conditions we call as true hyperkalemia and pseudo hyperkalemia. We'll be talking of that. We already mentioned three classical mechanisms: increase intake, decreased excretion and transcellular shift. We have already mentioned the commonest material, coconut water, citrus fruits, and pot chlor, either IV or orally. And there is one condition we call pseudo also. Even banana, excess of banana intake can also produce. Now, we have already mentioned all this cellular shift. So, any condition which shifts the potassium from intracellular compartment into extracellular compartment like acidosis, hyperglycemia, beta blockers, that is beta adrenergic antagonist, alpha adrenoreceptor agonist, increased osmolality, exercise, cell lysis, etc. will increase the potassium level. Indirectly, these are all the etiology of hyperkalemia. And cell lysis can happen in severe burns, rhabdomyolysis, tumor lysis, then even hemolysis, acute massive hemolysis, all those conditions. Also, in case of an insulin deficiency, particularly type 1 diabetes mellitus, you will have chance of increased potassium outside. While shift of potassium inside producing hypokalemia will be because of insulin beta adrenoreceptor agonist, alkalosis, and alpha adrenoreceptor antagonist. Specifically in respiratory acidosis, usually we don't end up with hyperkalemia. Also in a metabolic acidosis, particularly from organic acid like lactic acid, etc., we do not develop hyperkalemia. So this is what is to be known in case of a cellular shifts or cellular potassium shifts. We have already mentioned that in an acute kidney injury, there will be decreased GFR, and because of decreased GFR, decreased reabsorption of potassium, and potassium level in blood will be increased. And all these drugs like renin inhibitor, ACE inhibitor, angiotensin receptor antagonist, aldosterone inhibitors, potassium sparing diuretic, all will be acting on a distal convoluted tubule and preserving potassium. Also, decreased level of aldosterone will also result into elevated level of potassium. These are all the etiology as well as mechanism. So aldosterone will decrease, insulin will decrease, beta adrenergic agent will decrease, alpha adrenergic agent will increase, acidosis will increase, potassium alkalosis will decrease, cell damage, that is cell lysis, will increase, succinylcholine will also increase. So these are all the aldosterone will be acting on the kidney, insulin will be acting at the cellular level. This will be also acting at a cellular shift. Acidosis because of pH, H ions will also act at the cellular level. Cell damage will be release of potassium from cell lysis. So all these drugs will be acting at cellular level, while aldosterone will be acting at the kidney. This is hyperkalemia mechanism in CKD. At your leisure time, you can go through. Mainly in a CKD, it will be because of increased dietary intake or because of shift from extracellular space because of metabolic acidosis or because of the drugs. Also, you can end up with hyperkalemia. So, there will be acute kidney injury and the CKD. So, mechanism of hyperkalemia in AKI will be there because of decreased urinary flow and because of tissue injury. This is entirely regarding a hyperkalemia, complete mechanism, AKI, decreased GFR, tuberointestinal damage, anemia, etc. So you give blood transfusion, all that will increase the potassium load and end up with hyperkalemia. Insulin deficiency and hypertonicity because of hyperglycemia will also increase your potassium level. Hyperrenin conditions, Rash inhibitors, heparin, mineralocorticoids, cardiac glycosides, then cardiovascular disease, acute myocardial ischemia, left ventricular hypertrophy, congestive heart failure will also be one of the factors which will be affected by hyperkalemia. Then we already mentioned dietary modification, metabolic acidosis, etc., which is very common in CKD, will have effect on potassium level. So entire mechanism is being at your leisure time you can go through. This is what we call as a Rash system, again at your leisure time, because what is being acting will be aldosterone will be acting on a distal convoluted tubule, and that will be producing in kidney increased sodium and water reabsorption and increased secretion of potassium and H ion into urine. So if there is a decreased aldosterone level in blood, like hypoaldosteronism, or we create hypoaldosteronism by aldosterone antagonist, then person will end up with loss of preservation of potassium and H ions, leading to hyperkalemia and acidosis. And opposite of that, if there is an increased level of aldosterone, you will end up with hypokalemia and alkalosis. So pathogenesis of hyperkalemia, Rash and potassium excretion is being explained in detail here. If you are interested, you can go through. That is the drug which blocks spironolactone, epileron, etc. will block that and will have effect on sodium and potassium balance by acting on a collecting tubules and distal convoluted tubules. And also the drugs like amiloride, triamterene as well as trimethoprim will be acting by blocking sodium channel, and by blocking that sodium channel again potassium will be affected, that is potassium will be preserved, loss of potassium will be reduced. And even angiotensin receptor via altering the aldosterone level will be acting on a distal convoluted tubule. So level of potassium can be affected by dietary modification, metabolic acidosis, anemia where multiple blood transfusion if it is given, you are giving lot of potassium, kidney transplant, AKI, diabetes mellitus, cardiovascular disease, and heart failure also will be affected by potassium level, and those conditions will also affect potassium level. If we go through etiology, pseudo hypokalemia or factitious hyperkalemia is very frequently because of hemolysis while withdrawing the blood. Good number of RBC, if they get hemolyzed, potassium level will be elevated without elevation of potassium in blood. Also, while collecting the blood, if fist is closed tightly, then also, or it is called milking of the extremities. And if there is a thrombocytosis or leukocytosis in the person, and if it undergoes thrombocytolysis and leukocytolysis, the potassium level will be elevated. And we have already mentioned the commonest cause will be transcellular shift, decreased excretion, endogenous production like cell lysis, drugs which will have effect on kidney or on a transcellular shift, and dietary intake. So all this mechanism will be playing a role. We'll be mentioning few of the causes. One of the dietary material, that is banana and coconut water, plays a very important role. Or you give pot chlor, IV or orally. So banana and coconut water. Decreased excretion can be in AKI and CKD. Hypoaldosteronism will be acting via kidney, and in that particular condition you will have elevated level of potassium because sodium is not reabsorbed, sodium is lost, potassium is preserved, and that will end up with hyperkalemia. Addison's disease, because of cortisol level also will have elevation of potassium. Lack of cortisol will have elevation. Potassium sparing diuretic will also amiloride and trimethoprim. Also trimethoprim will be producing that by blocking sodium pump. ACE inhibitor ARB by blocking those production of aldosterone will produce indirectly hypoaldosteronism. And renal tubular acidosis will also result into that, where H ion is preserved and potassium is also preserved, and that will result into what is being called as renal tubular acidosis, and you will have hyperkalemia. Transcellular shift will be very common in acidosis, where intracellular will be shifted to outside. Cell lysis because of breakdown of the cell and potassium is released outside. Beta blocker will do the same. Hyperglycemia because of hyperosmolar condition will shift potassium from intracellular into extracellular compartment, and that all will end into increased level of potassium in blood. So pseudo hyperkalemia is because of hemolysis, thrombocytosis, severe leukocytosis, venipuncture with closed fist, clenching the fist, or milking of the arms, etc. Abnormal potassium distribution will be very common because of insulin deficiency, particularly in type 1 diabetes mellitus, person who are on beta blocker, or person who develops a metabolic acidosis, less common with respiratory acidosis. And again in metabolic acidosis, in case of lactic acidosis, usually less chance of hyperkalemia. Also you can see abnormal potassium distribution in a hyperkalemic periodic paralysis. Because of cell lysis like rhabdomyolysis, tumor lysis, as well as acute massive hemolysis can produce abnormal potassium release from the cell. Also this thrombocytolysis and severe leukocytolysis will also end up with high potassium. Excessive intake of potassium either orally or by IV, this will be iontogenic. And among oral intake, banana, coconut water, citrus fruits, as well as the other material which is rich in potassium. Hello. Just a minute. Chocolate. Huh? Ah. That's right. Sure. Chocolate. Decreased renal excretion will be very peculiar in chronic CKD, acute kidney injury. Disease like lupus, hypoaldosteronism, which will be decreasing the sodium reabsorption in a distal convoluted tubule and collecting system, and preserving potassium. Adrenal insufficiency because of hypocortisol level reduced, that will also have potassium preservation. In a heart failure, you will have a pseudo hyperaldosteronism. Drugs that inhibits the potassium excretion like amiloride, trimethoprim, trimethoprim, etc. They will be all. This is maximum common causes in your everyday practice. Other way to remember is by machine. M for medicines, A for acidosis, C for cellular, that is cell lysis, burns, traumatic injury, etc. H for hypoaldosteronism and hemolysis, I for excessive intake of food and salts, N for kidney injury, that is AKI, CKD, renal failures, and E for excretion, which is being impaired, whichever way you remember. So you can divide depending upon the renin and aldosterone level, that is hyporenin and hypoaldosteronism, like in case of diabetic nephropathy and person who are on large dose of NSAID for long period. If only aldosterone is low, non-hyporenin means renin level is normal or high, like ACE inhibitor, chronic heparin use, primary adrenal insufficiency, critical illness, and genetic disorders. There are some genetic disorders. And aldosterone resistance, where you got a high level of aldosterone and high level of renin, like aldosterone receptor antagonist, trimethoprim, and some genetic disorders. So this will be etiology classified according to aldosterone level, mainly hypoaldosteronism and aldosterone resistance groups. Then renal failure, we have already mentioned, hypoaldosteronism. The internal redistribution will be because of cell lysis like tumor lysis, massive hemolysis, rhabdomyolysis. We have already mentioned regarding medicines which will have a redistribution of potassium, that is from intracellular into extracellular compartment, like beta blockers, succinylcholine, etc. And also insulin deficiency, acidosis, exercise, and hyperkalemic periodic paralysis. These are all the mechanism which will lead to pseudo, or we call factitious or spurious hyperkalemia. So do remember all this. That is while collecting the sample. That is difficulty in collecting the sample, clenched fist. You shake the sample tremendously, so hemolysis takes place. If the contamination with anticoagulants, particularly potassium EDTA, cooling of the blood sample, hemolysis of the sample, and deterioration of the sample because it is stored for a longer period. All these factors. And pre-existing condition, we already mentioned two most common, thrombocytosis and severe leukocytosis. And if you come across acquired red cell disorders, you can divide into excessive intake, decreased renal excretion, and shift from intracellular. We have already mentioned almost majority of them. We have already mentioned. Don't forget heparin and excessive blood transfusion also, which can result into excessive input, we call iatrogenic. And we have already mentioned regarding renal excretion and shift, hyperosmolality, rhabdomyolysis, tumor lysis, drugs like succinylcholine, insulin deficiency, acidosis, etc. will result into hyperkalemia. These are all the material in fruits, vegetables, and other material where they are very rich in potassium, particularly coconut water, banana, kiwis, then citrus fruits like orange, orange juice, then mango, papaya. All these are rich, of which coconut water and banana is very rich. And among vegetable, avocado, beet, then beans, potatoes, pumpkins, and among other material like beans, salsa, potato salads, sweet potato pie, etc. Milk, they are good in potassium. So orange, banana, pineapple, potato, tender coconut, fresh vegetables, and among non-vegetarian, chicken and liver, they are rich in potassium. But highest in banana and coconut water. They are very, very rich in potassium. And these are the drugs which will have effect on potassium balance, which will reduce. So major causes of hypoaldosteronism and aldosterone resistance. And these are the drugs which will be having effects known to induce hyperkalemia. A good number of we have already discussed. One of the drug, don't forget, potassium penicillin. Because of hyperkalemia, if it is below 6, usually person do not end up with symptoms. They are usually asymptomatic. As the potassium rises, person will have a weakness and paralysis. And you will start seeing changes in ECG in the form of a peak T wave, ST depression. Then you will start getting prolongation of PR interval. P wave will disappear. QRS will widen, and then end result will be sine wave, and then person will go into cardiac arrest. So that will be very peculiar. So less than 6.5, almost asymptomatic, and main symptoms will be muscle weakness, more in the lower limb than upper limb, and ECG changes in the form of a tall T wave, ST depression, PR prolongation, P wave will disappear, widening of QRS, sine wave, cardiac arrhythmia, and cardiac arrest. You can remember as murder, M for muscle cramps, U for urinary abnormality, R for respiratory distress, D for decreased cardiac contractility, E for EKG changes, and R for reflexes. Because of that muscular weakness, reflexes will be affected. Other way to remember, because of muscle involvement, dyspnea, nausea, vomiting, fatigue, weakness, chest pain, frank muscle paralysis, paresthesia, palpitation because of cardiac arrhythmias, severe muscle weakness, and absent or depressed tendon reflexes. And in blood, you will be demonstrating that potassium level is more than 5.5. So again, multiple different ways to remember muscle cramps, drowsiness, fall of blood pressure, ECG changes, arrhythmia, abdominal cramps, diarrhea, oliguria. Oliguria will be seen in a AKI, more common in AKI, and we have already told you ECG changes if it is between 5.5 to 6.5 tall peak T wave. As it becomes more than 6.5 up to 8, QRS will widen, bundle branch block pattern, and when it becomes further high, P will become flat, P wave will disappear, and when it is more than 10, you will get sine waves, and almost person will likely to go into cardiac arrest. So neuromuscular junction, muscle twitching, paralysis, cardiovascular, irregular heart rates, ventricular tachycardia, ventricular fibrillation, and cardiac arrest. Because of cardiac arrhythmia, fall of blood pressure, and you will see ECG changes. GI tract, hypermotility, diarrhea, nausea, vomiting. Abdominal cramps, hyperactive vowel sounds. And as far as respiratory system is concerned, respiratory system failure will take place because of involvement of the intercostal muscle. Intercostal muscle becomes weak, and even the diaphragm can be affected. We have already mentioned regarding this ECG changes that you will have a tall T wave, ST depression, and then finally you will have a sine wave appearance. As the potassium level increases, widening of QRS complex, arrhythmia, and person will go into asystole. So peak T wave, prolonged PR interval, then loss of P wave, prolongation of QRS complex, ST segment changes, ectopic bits, then progressive widening, sine wave, and person will now start developing VTVF, asystole, might have bundle branch block, etc. As potassium rises above 8, and when it is 10, usually sine wave will appear. So you can see here appearance of sine wave, ventricular tachycardia, and person almost goes into cardiac arrest. And sometimes even a rapid rise of potassium can also produce changes quite early. So we have already mentioned this. So acute rise from 3.8 to 6.6 can also produce sudden cardiac arrhythmias because of effect of rapid rise in potassium, and this was seen with IV penicillin, which was containing potassium. So different changes can also mimic sometime, like Brugada syndrome, where you got an ST almost downsloping, which mimics identical like Brugada. Whenever you want to diagnose hyperkalemia, first always exclude pseudo hyperkalemia. So you can re-evaluate for potassium level. If that is ruled out, now go for renal function and medication list. Medication list is very easy to obtain from the person, prescriptions and previous drugs. And as far as the renal function is concerned, blood urea, creatinine, urinary potassium, urinary sodium, urine pH. So we call renal function test. And once that is ruled out, renal function is normal, no history of medication. Now you will go for examining endocrine etiology, that is hypoaldosteronism, renin level, aldosterone level, cortisol level. This should be a proper approach. We call step 3 approach. This is one of the algorithm which is being mentioned here. If there is an hyperkalemia and if it is more than 6 and there are ECG changes, if answer is yes, emergency treatment. If there is a pseudo and answer is yes, you don't require anything. Now suppose if the potassium level is not 6 and there are no ECG changes, now what you can do? Get a good history, do a good physical examination and basic laboratory parameters. Now if there is an evidence of drug induced like transcellular shift, answer is a yes, then treat according and re-evaluate again. Particularly, we try to rule out hypertonicity like mannitol, hyperglycemia, succinylcholine, digoxin, beta blocker, then acidosis, particularly metabolic acidosis, hyperkalemic periodic paralysis, type 1 diabetes mellitus, or even diabetic ketoacidosis and heavy exercise. Of this, whichever condition we identify, we try to treat that. If there is an evidence of excessive potassium load, get a good history, reevaluate and treat accordingly. So reduce oral intake. If there is no oral excess of potassium and there is no evidence of transcellular shift, now we have to evaluate for renal. So we do a urinary potassium excretion. If it is less than 40 ml, then urinary electrolyte should be done, that is urinary sodium, and then we go for a further checkup. So this will be in detail checkup for renal pathophysiology and trying to rule out endocrine groups of disorders like related to aldosterone, related to cortisol level and related to drugs which are acting on kidney or drugs which decreases or increases the potassium. In that you will be doing this. So this will be the conditions how we approach. So urinary potassium, then depending upon that urinary potassium, whatever is mentioned here, same thing is mentioned in detail here. You can try to identify diabetic ketoacidosis, renal tubular acidosis, then mineralocorticoid excess, Liddle syndromes, diuretic abuse, hypomagnesemia, then laxative abuse, etc. by urinary potassium excretion. Try to proceed with that. Whatever was mentioned, that this is in enlarged slide. So you go according to, if there is a decreased urinary potassium excretion, means less than 40 millimole per day, then we go for all these steps. This is little difficult, but you should keep it in mind. If you rule out oral, if you rule out transcellular shift, if you rule out cell lysis, etc., all those conditions, now you will be going for renal and endocrine groups of disorders. So investigations will depend upon serum sodium, potassium, chloride, calcium, phosphate, magnesium, blood urea, creatinine. Blood urea creatinine will give you idea regarding a renal pathophysiology. Magnesium can also have effect on potassium, and potassium level itself will give you an idea regarding hyper or hypo or normal. Osmolality can have effect on a potassium shift, intracellular and extracellular shift. Hematocrit will also help to rule out a blood condition which can elevate your potassium, and also try to rule out cell lysis by doing myoglobinuria, etc. Urinary level should be checked whenever you are suspecting renal or endocrine groups of disorders. Blood gases, that is ABG study, is important to rule out acidosis and alkalosis. CPK level will be very useful in particularly rhabdomyolysis. And ECG is absolutely must in all cases to find out the effect of potassium on myocardium. So serum potassium level, ABG, ECG is a must in all. And ECG becomes very useful, we have already discussed. You can go as a quiz. This is one, this is second one, which is showing you a ST depression with a peak T wave. This is, you can see the difference between mild, hyper, then slowly the P wave is becoming peak. You can see pinched peak T wave, and then when it is very severe, you get a sine wave. In severe hyperkalemia, you will get a sine wave, wide QRS complex with almost sine wave, and then later on it will go into what we call as torsada pointis, ventricular tachycardia, etc., and then cardiac arrest. This is a difference between periodic paralysis, that is hypokalemic, thyrotoxic, hyperkalemic, and Anderson syndrome. We are not much interested in that. This we suspect when we rule out all other conditions, we go for these groups of disorders. As far as management is concerned, treatment, if you identify the etiology and if it is treatable, treat the underlying cause. If person is having potassium level more than 6.5 and there are ECG changes, or even if the person is having 6.5 to 7, it should be treated. And therapies to remove the potassium from the body will be long-term effect, while there are some which are transient. We'll be discussing that. So first, stabilize the myocardial membrane by rapidly acting material and which is transient. And then if person again goes into hyperkalemia, in spite of treating with rapidly acting material like calcium gluconate, soda bicarb, or insulin drip, or albuterol, now you can go for removal of potassium from the body by means of resins, dialysis, or diuretic. This will have long-term effects. So stabilize the myocardium to prevent the cardiac arrhythmias. Drive the extracellular potassium into the cell by using calcium gluconate, soda bicarb, insulin, or albuterol nebulizer. And then last resort is potassium should be removed from the body by means of a potassium resins, hemodialysis or peritoneal dialysis, and diuretics, of which hemodialysis is best, second best is diuretics. There are some side effects of potassium resins. First thing, stop orally high potassium containing fruits, vegetables, and other materials. And also, if a person is on a oral potassium or IV pot clo, that should be stopped. So dietary control, if person is having acidosis, correction of acidosis, water correction, water balance, and sodium balance, that is hyponatremia. You can do that by calcium gluconate, insulin drips, bicarbonate infusion, potassium binding resins, and last is dialysis. This treatment of acidosis, calcium gluconate, soda bicarb, insulin drips are temporary. So if a person has got a mild hyperkalemia, usually furosemide may be enough, or you can go for potassium resins. If person has got an elevated level, moderate, that is more than 6 to 7, then you can go for glucose with insulin drip or soda bicarb or albuterol. If person is having severe, first calcium gluconate, insulin drips or albuterol should be tried, and even after that, if it is not, so always try first calcium gluconate, and then you can think about either potassium resin, hemodialysis or diuretics. So depending upon that, you go for the different treatment we have already mentioned. But there are certain things which you have to keep it in mind, that if person has got a pseudo hyperkalemia, you don't require any treatment. If answer is yes, emergency treatment. Then if person does not have a pseudo hyperkalemia, then laboratory evaluation, hyperosmolality, treat retained osmolytes and treat metabolic acidosis. If person is having history of excessive dietary intake, stop medicines which is going to produce hyperkalemia, and if GFR is reduced, you can consider diuretics, and if there is an obstructive uropathy, treat the obstruction. This will be an additional treatment what can be done. So first is protect the heart, then use the drugs or material which will shift temporarily potassium intracellular, and then you can think about removing the potassium from the body by diuretics or dialysis or potassium resins. And during all this treatment, monitoring of potassium and monitoring of glucose and prevent recurrence. That should be the goal, and that is how you do. Here everything is mentioned again same. You can go according to those different algorithms what you follow. So protect the heart, shift the potassium into intracellular compartment and remove potassium from the body by loop diuretics or resins or hemodialysis or peritoneal dialysis. And shifting can be done by glucose with insulin, salbutamol, soda bicarb, etc. So stabilize the membrane, increase the entry into the cell, remove the excess of potassium, and dietary restriction is a must. And this is the effect of each material: calcium gluconate, insulin, albuterol, furosemide, and resin. How long the effect will last, what is the mechanism, and what precaution you should take, that is mentioned here, and what will be the onset of action and how much dose to be given. If you are interested at your leisure time, you can go through. Resin is one of the material, but there are good number of side effects like GI upset, nausea, vomiting, and it can produce intestinal necrosis. This should be kept in mind, and it is always as a second line of treatment, after which if person does not respond, then you can use this. But if person is having hyperkalemia, moderate to severe, and if immediate dialysis is not possible, then only resin is being preferred. Diuretic is relatively safe if hyperkalemia is mild to moderate, renal function is not severely impaired, and other indication for diuretics are already there in that patient like hypertension and hypervolemia. Then that is the drug of choice. Hemodialysis is the best way of treatment for removal of potassium from the body, and it will be very helpful in end-stage renal disease, severe Ecg changes, and hyperkalemia induced arrhythmias. But always keep it in mind, after dialysis, rebound hyperkalemia is one of the possibilities. So first, always look at the potassium level and Ecg changes. To protect the myocardium, IV calcium gluconate is best. Then you can prefer insulin with glucose, salbutamol, and last is soda bicarb. You can recheck again, and depending upon that, you can decide regarding removal of potassium from the body, and that can be done by, we have already mentioned, that can be done by hemodialysis or diuretics or potassium resin. And one of the most important part, stop any material which is containing good quantity of potassium. So that will be all. So hemodialysis, peritoneal dialysis, complications is very common: hyperkalemic muscular paralysis, hyperkalemic paralytic ileus, cardiac arrhythmias, and person can die because of cardiac arrest and cardiac stents. So I end my lecture here on hyperkalemia. I hope this will be very helpful to you. This can be asked in your oral as well as in your theory, and you will see once in a while in your everyday practice a person who comes to you with a muscular weakness, has got some renal disease, who is on diuretics, etc. Those will be most common conditions which you will be coming across. If you like this particular lecture, don't forget to press button like, subscribe, and share with your friends. Thank you for taking out time. I know that your time is valuable, and I appreciate this for spending some of the time with me. See you in next lecture.